Hey everyone, this is Sign's Ask a Neurologist podcast. My name is Stephen Everett, and I'm a second year medical student at New York Medical College. Today I'm joined by Dr. Andrew Bauerschmidt, who is a neurologist and a specialist in neurocritical care here at Westchester Medical Center. Dr. Bauerschmidt, thank you so much for joining us.
Hi, thanks for having me today and your enthusiasm about neurology.
Absolutely. We love to share neurology with fellow students and anybody watching, and we always like to start by asking our faculty a little bit about what brought them to neurology. So I was hoping you could tell us a little about why you chose neurology as a specialty, whether it was something you thought about in undergrad or you knew your whole life
Mm,
you wanted to be a neurologist.
For sure. I did not know I was going to be a neurologist or even a physician until college, middle of college. But I knew I was interested in the brain, and I was interested in the mind as a more broader idea. I started college as a cognitive science major, which is a little more abstract, and then I switched to neuroscience, similar but a little more concrete biological sciences oriented. And then I decided I was going to, go to medical school after that. The mostly as a neuroscientist, there's a lot of fields you can get into, but medicine was a pretty obvious one. So I was always interested in that. And then even at that early stage, even as a freshman, I was doing some cognitive neuropsychology classes, and that's when I was first exposed to some of the more famous books in the lay press that are really neurology based. Oliver Sacks, some of his writing. I read Phantoms in the Brain, some other famous some books that really are um, excellent for they're interesting, but they really provoke these questions about what is the relationship between neurology and the human experience, and that's what was really intriguing. So studying neuroscience, went to medical school, and then in the course of medical school, I really did have an open mind about what field I would go into, but I realized that nothing was really as intriguing and deeply satisfying as neurology, as really understanding that connection. That I don't know how to say, a little more complexity. As much as interesting as I find other organ systems or other medical problems, nothing was as more, I think, intellectually intriguing. So it was a pretty clear plan after that.
Yeah, absolutely. That makes sense. I mean, there's so many unanswered questions and so many things in that field, especially coming from a cognitive science background. That's very
Mhm.
interesting to hear. Do you feel that anything in the cognitive science field sort of influenced, I don't know, maybe your research interests, like in college or in medical school or beyond, and sort of how do you connect those two things?
Yeah, I think pretty early on, I mean, in the whole realm of the neurosciences and clinical neurosciences, there's things that gravitate more towards I don't know if to use the term up higher level or lower level, but sort of lower level biological things and neurons and that level. And then there's the higher order things that, the culmination of all this stuff, cognition, psychology. Um, and I was definitely drawn towards the latter. And my research work since that time has actually been a couple of different focuses, but one is actually on the nature of consciousness and recovery of consciousness in coma and disorders of consciousness and that sort of thing. So I was definitely intrigued by that sort of higher order thing. And I remember very early on when I was reading freshman year, I took a course that was really a graduate level course, but it was a cognitive psychology of vision. And I remember to this day how much of an impact that had on me, reading about the phenomenon of blind sight, which is a sort of a phenomenon where you can have, a lack of cognitively or a lack of consciously perceived vision and yet have a response to visual stimuli. And that disparity, which is so fascinating, really intrigued me so much about why or what our experience is really like and what it really consists of. So it was pretty early on that I knew those things were intriguing to me. And then being able to see a path where you could turn that into a excellent professional career, seemed like a good road. Yeah.
And especially in discussing your more recent research and sort of these questions of cognition and recovery, as a neurocritical care specialist, is that sort of what drove you to the fellowship, or did you pick the fellowship and then sort of incorporate the research after the fact?
I think deciding what kind of subspecialty, once you're in training in neurology, then there's a lot of different elements to it. From a uh, academic perspective, yes, there's really only a few areas where you can study consciousness and disorders of consciousness in clinical practice, and it's really either epilepsy in looking at seizure subtypes that reproducibly cause impairment of awareness or consciousness, or in looking at coma recovery or severe brain injury, which we is what we deal with in neurocritical care. So keeping that at least in the back burner. And the other major component, which I think everyone has to think about, is practice environment. And I love all of neurology and all the subfields within it, but I realized pretty early on that I am drawn towards the acute care spectrum within neurology, and I think I wanted to be in a hospital environment and that kind of thing. So it all kind of lined up, and I had great mentors even before I made that final decision in neurocritical care in residency, and it was for me it was relatively clear cut. It wasn't something I struggled over too much.
And so you've talked about sort of what brought you to neurocurricular care. For those who aren't so familiar with the subfield, can you provide like a broad overview, if you will, of who you see, what you treat, and you go into a day of work, what are you faced with?
For sure. Um, we take care of all patients who have acute brain injury or at high risk of having neurologic impairment or problems that need a ICU level of care. So that sometimes patients who just are, sometimes it's just post-operative patients who need to be monitored very closely because they're at high risk of having deterioration. But it's more commonly patients who have acute brain injuries that need not only monitoring, but also a lot of intervention. And that takes a lot of form. We have a lot of patients, probably the patients we take care of cluster around a couple diagnoses with a long tail of less common things. We take care of a lot of patients with strokes, ischemic stroke and hemorrhagic stroke, just because of the sheer number of those patients that we see in the population. It's a relatively common, type of severe neurologic disorder. Patients who have small strokes tend to get taken care of in the regular hospital floors, but the ones that have such large strokes that they either need neurosurgical intervention or they have secondary impairment of other organ systems. They have respiratory failure. They have swelling in the brain, things that need more specific and intensive monitoring or interventions is the ones we take care of. And it's we also take care of traumatic brain injuries. We have patients with refractory seizures, status epilepticus, patients with meningitis, encephalitis, traumatic brain injuries, traumatic spinal cord injuries, and then a long list of slightly less common things, but the things that need a good neurologist and a good intensivist in the same place.
That was my follow-up question. To that was going to be sort of what's it like interacting with other specialists in the hospital versus, it sounds like you kind of do a lot of the things, the other
Mhm.
specialists might think of. You're thinking about respiratory questions, you're thinking about neurological questions, you're thinking about cardiovascular questions. So what is it like in the neuro ICU when it's you and then it's sort of the whole team? Like how does that work exactly?
Sure. It's important to take a look at actually how neurocritical care as a field started. It really only started in the 90s. Before that, the general paradigm for these kind of patients was you would have a intensivist, a critical care doctor who would take care of critically ill patients and the other organ systems, and then generally a neurologist and or neurosurgeon, depending on what's going on, guiding the management of the neurologic problem. The problem with that is that the sort of perspective on all these things and the language used for critical care physicians is very different than that of most neurologists. They just kind of talk different languages. They kind of weigh things a little bit differently. And as much as you can work together, it's kind of evolved over time that it's probably best to have someone who's trained in both fields and really understand both fields to take care of the patient in a unified fashion. So that's how the field developed. And so we take care of most of what's going on with the patients. We need to work with subspecialists for complex problems in certain fields. The fields that we work with most closely are probably neurosurgery, as a lot of the patients are, some of them are primarily surgical patients that we more are supportive of their, primary neurosurgical problems. And some are patients who have whatever may be structural, problems in the brain, strokes, trauma. They will need a neurosurgical intervention as part of their care. So it's something that we work really closely with them, and that's honestly, it's really enjoyable. And then we have other care providers in the team. We have mid-level providers, nurse practitioners. We have residents and fellows training in various specialties. So it really is a big multidisciplinary team, is what it's like, and every day. And actually, all critical care, I think particularly neurocritical care, is really about teamwork and organizing a team that is multifaceted, because it's just too complex to be in little independent silos.
Very interdisciplinary within, your team, and thinking about sort of
Mhm.
all the different problems and how they can sort of culminate in just, with what you're all doing right there.
Yeah.
And you mentioned the training of residents and fellows as well. So if we've been talking a lot about the subspecialty. So if we zoom out a little bit, can you talk a bit about your residency training and then how that sort of differed between residency to fellowship and now as an attending, sort of how those different stages were in terms of your hours or in terms of work, and sort of how it looks now, looking back on all those years?
Sure. So I was a neurology resident at Columbia University Medical Center, and it was a great experience. But it was like all residency training. It was pretty intensive. You have long hours. It is primarily, and most neurology training is fairly heavily inpatient focused, with a good outpatient chunk mixed in, just because you get I think a much broader case mix and variety of types of patients and sicker patients, more complex patients, that way. Um, the fellowship is varies a lot more. I think all fellowship programs, there's a lot more variation between them. Neurology programs, there's certainly variation, but there's more standardization. Fellowship can be a little bit Wild West. It can be there's some rules and regulations, but less. Um, but it's a fantastic time. I had a great fellowship experience. I stayed at New York Presbyterian. It was a mixture between the Columbia and Cornell campuses, and the neuro ICUs there. And it was a pretty intensive experience, but one that really lets you step into the role of being an almost attending, and that's really the point of fellowship, is to uh, like any stage of training, you're trying to operate the eye towards the level above you. You want to, as a resident, you want to, one of the best, I keep going back a second, but one of the best accolades you can give to a medical student when you're in a rotation, if you're doing a review at the end of the rotation, to say they, functioned like a first year resident. That's like means that you're operating at the step above. And that's really how residency works. You want to be operating at a fellow level. And as a fellow, you want to be pretty much operating like an attending, just getting the opportunity to do it with that backstop. Um, so yeah, my experience was good, and I just tried to work at the level ahead of my own.
Definitely makes sense, and always something to strive for all the medical students who are listening. That's
Mhm.
definitely a good
See
throw.
what see what the junior residents are doing, and then
Yeah, exactly. Um, so just a bit more about the field then, since you mentioned it's such a new development. I imagine there's been, even in the last 20, 30 years, there's been the amount of change must be really condensed. So I'm curious as to what you think changes will be in the field, maybe in the next 5 years, the next 20 years or so, that you expect or that you would want to see in your field.
Mhm. So I think it's changes that have already happened, is that awareness of how to take care of these kind of patients, uh, and the benefits that have come from that are already happening. If you look at mortality data, and outcomes data for some of the just core things we deal with, subarachnoid hemorrhage, for example, outcomes are dramatically better than they were just 20, 30 years ago. And I think, the field of neurocritical care has a big role to play in that. Standardization of how to take care of these patients, because, I'll say this from the outset. Neuro patients are weird, like, and everyone sort of knows this. It's like, especially when you have, sometimes nurses who float to the unit, they're like, neuro, like, it's hard to even know what's happening with these patients, right? Some of them are confusing, they're confused themselves. It's not as intuitive as some other types of patients. So I think it's harder for less experienced centers or caregivers to get used to taking care of them. And I think our field has helped a lot to educate and grow that. Where it's going is interesting. It's our field has a lot of opportunity for, in my opinion, movements in informatics and actually in the ICU. There's obviously every field of medicine is expanding with regards to long-term data, research work, but the amount of data that can be generated from a very sick neurocritical care patient is very high. In our unit, we have patients who have, besides standard critical care monitors and ventilators and this sort of thing, vital signs, we have a lot of intracranial monitors. We use EEG, we use depth EEG, use quantitative EEG. We have monitors in the brain, external monitoring devices. And the reason for that is because when we have patients who are really sick, you don't have a good neurologic exam to follow. The thing that happens, as you go through neurology training, you realize the neurologic exam is an extremely potent tool. And the art of physical exam in some fields is, in some ways, I don't want to minimize it, but is a dying art. And because we have tools that have displaced that. The neurologic exam in the right hands is extremely powerful, and it's more powerful than any technology when you have an awake or an interacting patient. But a lot of our patients have such significant injury that, at least transiently, they may be comatose. And you need technology to help tell you what is going on when you don't have much of a neurologic exam to go on. So the end result of that is that you have a ton of data. And as you see what's happening in the world, we are emerging into a space where there's tremendously powerful tools for collating, analyzing, and turning that data into something really useful in a powerful way. And medicine and technology tends to be 10 or 15 years behind what's happening in the outside world. It's just the nature of it. Regulations, approval, that kind of thing. So I think where it's going is we have to really shift that, what is happening in other spaces in the world, and apply it to medicine in a proactive way to turn all that data into a useful field. And I think we have the most low-hanging fruit space in neurocritical care because we generate the most data of any other critically ill population, I think. So there's a lot of opportunities for that.
Lots of data to analyze. Just the question
Lots
is
of data, yeah.
But
analyzing data, once you get to the point that it's analyzed, is still relatively easy. But putting it all in one place, having it all make sense, having it all referenced is complicated and hard. So
that sort of flows into my next question, is sort of to discuss maybe some of the challenges in the field. So it sounds like that just this insane amount of data that there is, and there's all of these metrics and things that come together. Are there other challenges that you faced, or that you hear your colleagues are facing in the field, and sort of what are some ways that you're hoping those will be solved?
For sure. I think really the challenges that I've seen in colleagues at different places, and that you hear about, neurocritical care is at the interesting junction of, when you have a functioning neurocritical care service in a hospital, it's at the intersection between, other critical care services, MICU, pulmonary critical care, anesthesia, and neurology departments, neurosurgery department. And as a result, it's one that is prone to having difficulties if there's political issues within a hospital system, within departments. So the quality of the relationships and the collegiality of the relationships between those different parties is really important. It really will make or break your experience as a physician working in that field. So it can be challenging. Thankfully, I would say the relationship we have between these different parties at Westchester, is fantastic. It's the best I've ever experienced, and really the best I hear about, talking to a lot of colleagues and with people in our team who have been a lot of other institutions. So that part's great. But it's something that has the potential to be a trouble in different institutions. So.
It goes back to what you were talking about with teamwork and the leadership that you really need to show, whether it's just with your colleagues or like between other departments. Surely
Mhm.
that'll be important when you're dealing so closely with fields that are related, but at the same time, not quite doing what you're doing, it sounds like.
For sure. Yeah.
And our last few questions, I suppose, what would you say to either aspiring neurologists or M1s who haven't taken their neuro course yet or are in the middle of it? How would you, more than you've already done, sell neurology, or why do you think it's the specialty to go into?
I mean, neurology is fascinating. All right. And like I was saying about neurology patients being challenging, it's everyone who's in neurology sees that, understands that, but really enjoys that. It's worth it. The patients are never boring, always interesting. Um, I'm sure everyone who does whatever field they're in enjoys it. But as interesting as the kidneys are, there's only so many things that are going to go up, go down, only so many things to happen. And no other fields has this other layer in it, or that, really the patients we deal with really uh, prompts questions for us, which are interesting about who we are, what's the nature of our own cognition, the nature of our own experience. And if you find that interesting or find that meaningful to deal with, among other, excellent, interesting things about the field, then it's there's no other option. That's it.
Well, I would certainly agree. I suppose I'm pretty biased, but I think that's
Mhm.
a great way to put it. And my last question is, what is something that you feel encouraged by in your practice, whether it's in your patients, with your colleagues, or in your own practice that you've seen over time? What's something that, keeps bringing you into work and keeps having you want to do this job?
Yeah. It's we have, in the neuro ICU, we see a lot of crazy stuff. We see a lot of real tragic things, patients who are sick, don't survive from things that are sometimes kind of random or accidents, or we're just unfortunate, like any other critically ill population, that happens. But we also see incredible recoveries, and that is encouraging. And it's more so than other places. Sometimes we see people who are very sick or very debilitated, and they can have amazing recoveries, and that's the thing. The Yeah, and that's what makes it worth it.
It's so important to hear you say that because I know a lot of people think, well, neurology is a field where you can't treat anything. You can diagnose somebody and then, that's all. But to hear that you can say there really are all these possible recoveries is such a great advance and such a great thing to hear.
And that's just in my field. I mean, neurology, if you looked at it 30 to 40 years ago, it was when you call it diagnostic oriented field, and there was very limited treatment things. You had a handful of diagnoses, that you had a handful of medications that were really helpful, and that was it. But neurology is really transforming into a really therapeutic driven field. We really do have a lot to offer. I mean, in some fields, it's actually tremendous. I mean, if you look at what's happened in stroke and interventional stroke, you look at what's happened in multiple sclerosis. Multiple sclerosis 40 years ago was, often a death sentence. It was really bad, and now it's a very, very treatable disease. Um, Same goes for tons of other conditions. So neurology really, I think people who say that or hear that are not well informed, and it's really become something that's a very active field in all regards.
And that's so encouraging to hear, and I think a great place to close. So, Dr. Bauerschmidt, thank you so much for joining us. And I'm sure if anyone has any questions, they know where to find you.
For sure, for sure. Thanks for having me.
Thank
Pleasure.
you.